Welcome back to the deep dive. Today we are actually doing something a little bit different. Usually, we take a broad topic and we just sort of explore the nooks and crannies for general interest, but today we have a very specific mission.
Yeah, we really do. We are essentially acting as the ultimate study buddy for a very specific group of people today, urologists.
Right, exactly. So if you are a urology trainee, a resident, or, an attending preparing for your board exams or recertification, this deep dive is completely custom built for you.
We are doing a comprehensive, line-by-line analysis of the 2025 EAU guidelines on urological trauma.
And I know what some of you might be thinking right now. You're thinking, guidelines,
Yeah.
dry PDFs, endlessly scrolling through those massive tables.
It sounds painful, I know.
It does. But here's the thing. Trauma is the one area in urology where you really, really can't just wing it. When a patient rolls into the ER, you need an algorithm in your head. You need a flowchart that activates instantly.
Exactly. Trauma is high stakes, it's high pressure, and honestly, it is extremely high yield for exams. The examiners absolutely love trauma because it forces you to make decisions under duress.
Right, like do you scan, do you cut, do you wait?
Yes, and the 2025 EAU guidelines have very specific evidence-based answers to all of those questions, so you can't just guess based on instinct.
So our goal for this hour is to take that dense PDF document and literally convert it into a mental framework for you. We are going to go organ by organ. So kidney, ureter, bladder, urethra, genitals, and we are going to extract the gold nuggets that you absolutely need to memorize.
And we're going to focus on the what, but more importantly, we really want to dig into the why. Because if you understand the pathophysiology and the evidence base behind the rules, you don't have to rely on rote memorization. It just makes physiological sense.
I love that. Let's start with the mindset then, before we even touch a kidney. Set the stage for us. What is the overarching philosophy of the 2025 guidelines?
The biggest shift we have seen over the last 2 decades, which is really solidified in the 2025 text, is the massive move toward conservative management, or non-operative management, which you'll see abbreviated as NM.
NOM, right?
Yeah, we used to explore everything. A couple of decades ago, if there was blood, we went in. Now, we are incredibly reluctant to open a trauma patient unless we absolutely have to.
So it's basically the don't just do something, stand there approach.
In a way, yes. But it is more like stand there and watch like a hawk. You have to be incredibly vigilant. The other major philosophical pillar here is damage control. You have to recognize when a patient is simply too sick to be fixed perfectly.
And this brings us right into the general principles section of the guidelines. They talk a lot about polytrauma right up front, because we aren't just treating a kidney in a jar, right?
Exactly.
We are treating a human being who might have a shattered pelvis, maybe a liver laceration, maybe a brain bleed.
Correct. And the data shows that managing polytrauma in a specialized major trauma center reduces mortality by 25%.
25%. That is a massive number.
It really is. But for the urologist specifically, the key concept to grasp before you do anything is the lethal triad.
Oh, I remember this from med school, but let's refresh it. The lethal triad. Walk us through it.
It is hypothermia, coagulopathy, and acidosis. Imagine the physiology here. A patient is bleeding heavily, so they go into shock. We strip them naked in the trauma bay to assess them, so they get cold. That's your hypothermia.
Right, they're losing heat rapidly.
Exactly. And because they aren't perfusing their tissues with enough oxygenated blood, the body switches to anaerobic metabolism. They build up lactic acid. That is your acidosis.
And then the coagulopathy comes in.
Yes. And here's the picker that you have to understand for the boards. The enzymes in your body that clot blood are highly temperature and pH sensitive.
Oh, wow.
Yeah. They simply stop working when you are cold and acidic. So you get coagulopathy. You can give them all the platelets and plasma in the world, but if they're cold and acidotic, their blood will just not clot.
So it is just a complete death spiral.
It really is.
Yeah.
And the guidelines are very, very clear on this. If the patient is in the lethal triad, you do not perform complex reconstruction.
So no 3-hour ureteral reimplantation or a fancy partial nephrectomy?
Absolutely not. You do damage control. You stop the bleeding, you control the contamination, and you get out of the operating room.
Right, yeah.
Stick it in a nephrostomy tube, you pack the wound with sponges, you close the skin temporarily, or even leave it open with a vac dressing, and you send them straight to the ICU to warm up and correct that coagulopathy. You survive today so you can live to fight another day.
And that is a classic board exam trap, isn't it? They give you a clinical vignette with a stable patient, and the answer is to fix it, but then they give you a patient with a pH of 7.1 and a temp of 34 degrees Celsius.
And if you select the multiple choice option that says, I am going to repair the renal pelvis, you fail the question. The answer is always damage control, temporary drainage, ICU.
Okay, let's talk about two other general things before we actually hit the individual organs: thromboprophylaxis and antibiotics.
This one is super interesting because urologists are generally terrified of bleeding. I mean, we see a trauma patient with a retroperitoneal hematoma, and our first instinct is, I am not giving this person heparin.
Right, because you don't want the hematoma to get bigger.
Exactly. But the 2025 guidelines actually recommend established prophylaxis measures, specifically low molecular weight heparin, or LMWH, despite the hemorrhage risk.
Really? Even with an active renal bleed or a recent one?
Yes. The risk of DVT and pulmonary embolism in bedbound trauma patients is incredibly high. The evidence heavily suggests that the massive benefit of preventing a fatal PE far outweighs the risk of expanding the hematoma in the vast majority of cases.
That is a huge takeaway. And what about bed rest? I feel like we used to keep people flat on their backs for days.
The practice of strict, prolonged bed rest has really waned. If they are hemodynamically stable, we actually want them moving as soon as safely possible to prevent those exact clots.
Got it. And antibiotics. Do we just blast them with broad-spectrum antibiotics because there's urine leaking somewhere?
No, this is all about antibiotic stewardship now. There is no hard evidence that you need prolonged antibiotics just because there is a hematoma or some urinary extravasation.
So no 2-week courses of vancomycin and Zosyn.
Right. You follow local policy, which is usually just a short prophylactic course. Don't keep them on heavy IV antibiotics for 2 weeks just because there's a bit of urine in the retroperitoneum.
Okay, fantastic. So let's dive into the meat and potatoes of the guidelines. Section 1, renal trauma.
This is the most common urological trauma you will see. Up to 5% of all trauma cases overall involve the kidney to some degree.
And to talk about this properly, we need to speak the language of the exam. That means knowing the AAST grading scale inside and out. That's the American Association for the Surgery of Trauma scale.
Right. And there is a slight nuance here you should be aware of. The 2025 guidelines mention the 2018 update to this radiological scale, but they also note that a lot of the historical literature you'll read is based on the older 1989 scale.
But for the purpose of the exam, you need to know the definitions clearly. Let's run through them quickly, sort of visualizing the kidney as we go. Start with grade 1.
Grade 1 is basically a contusion. It's a bruise on the kidney or a non-expanding subcapsular hematoma. The capsule is intact. The parenchyma is mostly fine. Just a bruise.
Okay, pretty straightforward. Grade 2.
Now you actually have a laceration, but it is superficial. It is less than 1 centimeter deep into the cortex. And crucially, there is no urine leak. Or you might see a non-expanding perirenal hematoma that is totally confined to Gerota's fascia.
Got it. Grade 3.
The laceration gets deeper. Now it is greater than 1 centimeter deep into the renal cortex, but, and this is the absolute key dividing line, there is still no collecting system injury, no urine leak whatsoever.
Okay, so I want to highlight that for everyone listening. Grades 1, 2, and 3 are all grouped by the fact that there is no urine leak.
Correct. That is the fundamental dividing line in the AAC scale, because grade 4 is where the game changes completely.
Let's hear grade 4.
Grade 4 is a laceration that extends all the way into the collecting system. So when you do a delayed scan, you will actually see contrast extravasation leaking out. Or it can also be a segmental vascular injury, meaning a branch of the main renal artery or vein is hit, which causes a segmental infarction of the kidney.
Okay, and finally, grade 5, the absolute catastrophe.
A shattered kidney, just multiple deep lacerations breaking the kidney into pieces. Or a hilarous ulsion. This is where the main renal artery or vein is literally torn right off the aorta or the vena cava. Or you have a completely devascularized kidney with active, massive bleeding.
Okay, so we have our grades memorized. Now let's put this into a clinical scenario. The patient comes in, they've been in a bad car accident or maybe a bar fight. The big high-yield question is, who gets a scan?
Right, because you don't scan everyone.
Exactly. Do we scan everyone who just got punched in the flank?
Definitely not. And this is a high-yield memorization list for the boards.
Yeah.
You absolutely need to know the indications for renal imaging in adults. And when we say imaging, we mean a multi-phase CT scan.
Give me the list. Let's break it down. Number 1.
Number 1 is visible hematuria, gross hematuria. If there is blood at the meatus or they are peeing bright red blood, you scan them, period.
Easy enough. Number 2.
Number 2 is non-visible or microscopic hematuria, PLUS shock.
And how are we defining shock in this context?
Shock is defined as a systolic blood pressure under 90 millimeters of mercury at any point.
At any point. So even in the field?
Yes. If they had one episode of hypotension in the ambulance with the paramedics, even if their pressure is totally stable right now in the ER and they have microhematuria, you scan them.
What if they have microhematuria, but they were never unstable? Their pressure has been perfect the whole time.
In a blunt trauma adult, you technically do not have to scan them based on that alone, but you have to look out for the other criteria, which brings us to number 3, rapid deceleration injury.
Yeah.
Yeah, even without any hematuria at all. If they fell from 4 stories up or they hit a tree at 60 miles per hour, the sheer force of that sudden stop can avulse the renal pedicle.
That is the silent obstruction, right?
Exactly. It is an intimal tear inside the vessel. The artery stretches, the inner lining tears and curls up inside like a scroll, and it completely blocks the blood flow.
But there's no blood in the urine.
Right. The kidney is dying from lack of oxygen, but because absolutely no blood is getting to it, it isn't filtering anything. It makes no urine. So you see 0 blood in the bladder.
Yeah.
You strictly need the scan to see the lack of enhancement in that kidney.
That's a scary one. Okay, number 4.
Penetrating trauma. If it is a gunshot wound or a stab wound anywhere in the box, meaning nipples to pubic bone, you scan.
And number 5.
Clinical signs: severe flank pain, lower rib fractures, massive bruising over the flank, things that just point anatomically to the kidney.
You mentioned multi-phase CT earlier. I really want to dig into that. Why can't I just ask the ER to do a standard portal venous phase CT of the abdomen and pelvis?
Because you will miss the diagnosis. You absolutely need 3 distinct phases.
Break them down for us.
First, the arterial phase. You need this to see the vascular injury and any active pumping arterial bleeding. Second, the nephrographic phase. This highlights the parenchyma so you can accurately see the depth of contusions and lacerations.
And the third phase, the one that everyone forgets.
The delayed phase, the most important one that gets missed all the time.
The 5-minute delay.
Yes, you need to wait at least 5 to 10 minutes for the contrast to be filtered and excreted into the collecting system. If you do not do a delayed phase, you will completely miss a grade 4 injury.
Because the contrast hasn't reached the renal pelvis yet.
Exactly. You won't see the urine leak simply because the contrast hasn't made it down there to leak out yet.
Okay, so let's say we did the right scan. Multi-phase, we have grade 4 injury, there's a deep laceration into the pelvis, we see some urine leaking out on the delayed phase. What do we do?
In 2025, the answer is almost always non-operative management. NOM.
Even for a grade 4?
Yes. For blunt trauma, grades 1 through 3 are obvious observation and bed rest. But here is the kicker that trips people up. Grade 4 is also mostly conservative now.
Wow.
And even grade 5,
Yeah.
the shattered kidney. If the patient is hemodynamically stable, over 50% of those can be managed without open surgery.
That is just wild to me. A completely shattered kidney, and we just sit back and watch it.
If they aren't bleeding to death,
Yeah.
yes. You have to remember the anatomy. The retroperitoneum is a very tight, confined space. It tamponades itself. The bleeding builds pressure, and that pressure stops the bleeding.
Right.
If you go in there and open Gerota's fascia, you release all that built-up pressure, the tamponade is gone. You'll likely end up doing a nephrectomy that wasn't actually necessary, simply because you can't control the bleeding once it starts again.
But surely there are exceptions. There have to be triggers. When do we actually intervene?
There are 2 main ways we intervene: angioembolization or open surgery. Let's talk about angio first, because this is the best friend of the modern conservative urologist.
Selective angioembolization, SAE. What are the triggers for sending someone to interventional radiology?
If you see active contrast extravasation on the CT, the classic blush, that means there is active arterial bleeding right now. Or if you see an AV fistula or a pseudoaneurysm forming.
Is there a predictor for who is going to fail conservative observation and ultimately need angio? Like, who should we be watching extra closely?
Yes, and the guidelines mention a very specific finding: active extravasation of contrast, PLUS, a large perirenal hematoma. And they define large specifically as a depth greater than 25 millimeters.
Greater than 25 millimeters.
Yeah. If you see that big hematoma and an active arterial blush, they're probably going to fail observation and they need angio immediately.
What if you embolize them, they go to the ICU, and then the pressure drops again, they are bleeding again? Do you take them to the OR then?
Actually, no. You embolize them again. Repeat SAE is highly recommended before you take them to the OR.
Really? A second round of angio?
Yes, because it prevents nephrectomy. Every single time you selectively coil a bleeder in IR, you save the rest of the kidney parenchyma. If a surgeon opens them up in the OR, they usually have to take the whole kidney to stop the bleeding.
Okay, so when do we actually sharpen the scalpel? When do we do a surgical exploration?
Hemodynamic instability that is unresponsive to fluid and blood resuscitation. That is the absolute unquestionable indication. If you are pouring blood into them and their blood pressure just isn't coming up, you have to go in.
Makes sense.
Also, if the general surgeons are already in the OR for something else, like a ruptured spleen or bowel, and they see an expanding or pulsatile hematoma in the retroperitoneum,
What if they see a stable hematoma while they're in there?
you tell them to leave alone.
Yeah.
Do not open Gerotis fascia on a stable hematoma if you are in there for a bowel injury. You will regret it instantly. You lose that tamponade effect we talked about, and suddenly you are in a massive, life-threatening vascular fight.
Okay, let's say we are forced to operate. Unstable patient, gunshot wound to the abdomen. We go in. How do we get to the kidney safely?
You use a transperitoneal approach. And the absolute rule is you need to control the main renal vessels before you open that hematoma.
Because if you open the hematoma first,
The kidney explodes with blood and you can't see anything. You'll be operating blind in a pool of blood.
so how do we get that vascular control before we even see the kidney?
You use the Cattle-Brash maneuver. This is incredibly high yield for surgical technique questions on the boards.
Walk us through it.
It is a right medial visceral rotation. You incise the white line of Told on the right side, and you literally lift the entire ascending colon and the small bowel mesentery up and off the retroperitoneum.
Just swing it out of the way.
You swing it right up onto the patient's chest. This maneuver completely exposes the inferior vena cava and the aorta. From there, you can identify and clamp the renal artery right at its origin on the aorta before you ever even touch the kidney itself.
That is a mental image everyone needs to have locked in. Lift the colon, find the great vessels, clamp the artery, and only then do you explore the hematoma.
Exactly. Control the tap before you try to fix the leak.
Brilliant. Before we leave the kidney, let's talk about follow-up. Let's say you manage them conservatively, they do great, they go home. Do they need another scan?
For grades 1 through 3, no. If they are clinically well, there is no need to expose them to more radiation. But for grade 4 and 5, or penetrating injuries, yes.
When do we scan them?
The guidelines strongly recommend repeat imaging 2 to 4 days post-trauma.
Why that specific window? What are we looking for?
You are looking to catch the complications that are completely silent but extremely dangerous. Things like uranomas building up or pseudoaneurysms that might rupture later. You really want to see those on a scan before the patient crashes at home a week later.
And long-term. Are there any long-term things we need to monitor?
Yes. You must check their blood pressure annually.
Ah, renovascular hypertension, the Page kidney.
Exactly, the Page kidney. The hematoma heals and forms tight scarring around the kidney. That scar tissue compresses the parenchyma, causing ischemia. The kidney thinks the body's blood pressure is low, so it activates the renin-angiotensin system, driving their blood pressure through the roof. It is rare, but you have to check for it.
Yeah, okay, moving down the track, section 2, ureteral trauma.
The silent injury. The ureter is incredibly well protected. It's small, it's highly mobile, and it is buried deep in retroperitoneal fat. So it is very rarely injured by external blunt trauma.
If it is blunt trauma, it's usually a massive deceleration injury, right? Like a UPJ avulsion where it tears right at the renal pelvis.
Correct. We see that especially in kids because they have very flexible spines that allow for massive hyperextension. But the vast majority of ureteral injuries are iatrogenic.
Meaning we did it in the hospital.
Right. It's the gynecologist doing a difficult hysterectomy, or the colorectal surgeon doing a low anterior resection, or it is penetrating trauma from the outside, like gunshots.
So what is the trap when it comes to diagnosing a ureteral injury?
The trap is thinking that a normal urinalysis rules it out.
Hematuria is unreliable here.
Completely unreliable. Gross or microscopic hematuria is actually absent in 25 to 75% of all ureteral injuries.
That is staggering. Over half the time, there's no blood.
Think about the physics of it. If the ureter is completely transected by a bullet or a scalpel, the urine and the blood leak straight out into the retroperitoneum. They never make it down into the bladder. So the ER dipstick reads perfectly clear, but the patient has a completely severed ureter.
That is terrifying. So how on earth do we find it?
A very high index of suspicion. If you suspect it, say, a gunshot wound anywhere near the course of the ureter, You absolutely need that CT urography. And again, you need the delayed phase. You are looking for that contrast leak.
What about intraoperatively? The general surgeon is operating, they see some fluid, they call you in.
If you were in the OR and they say, hey, I think I cut something, you inject dye. You give the patient intravenous methylene blue or indigo carmine, if you can find it these days. You wait a few minutes, and you look for the blue fluid pooling in the surgical field.
Okay, let's talk management. The surgeon calls you, the patient is on the table, abdomen is open, they definitely cut the ureter. What do you do?
If it is recognized immediately, right then and there, you fix it immediately. Primary repair is always your best option.
But what if it's a damage control situation? The patient is crashing, pressure is 70/40.
Then you ligate it.
Just tie it off.
You literally tie off the ureter with a heavy silk suture, you stick a percutaneous nephrostomy tube in their back to drain the kidney, and you fix the ureter another day. Do not try to sew a delicate, watertight ureteral anastomosis in an unstable coagulopathic patient.
Because it won't heal.
It will completely fall apart, they will leak urine everywhere, and they might die on the table while you're messing with it.
Okay, but let's assume they are stable. We need to reconstruct. Give me the rules of thumb for surgical repair based on the location of the injury.
It is all about where the injury is. If it's the upper or mid-ureter, you do a ureterosterostomy.
Explain the technique for the exam.
You spatulate the ends. That means you cut the ends of the ureter longitudinally at an angle to make the openings much wider. Then you sew them together, absolutely tension-free, over a double J stent.
Tension-free is the magic word there. What if it's the distal ureter down near the pelvis?
The distal ureter has a very tenuous blood supply coming from the iliac vessels. If you cut it, you usually can't just pull the distal stump up to meet the proximal end. The blood supply won't survive the tension. So you reimplant it. Ureteroneocystostomy. You plug the proximal end directly into bladder.
What if there is a huge gap? A gunshot took out 3 inches of ureter and you can't reach the bladder.
Then you bring the bladder up to the ureter. You do a psoas hitch.
How does that work?
You mobilize the bladder. You cut the contralateral vascular pedicle to free it up, and you literally stretch the dome of the bladder upward and stitch it to the psoas tendon. This gives you several extra centimeters of length.
And if that still isn't enough?
If it is a really massive gap, you do a Bory flap. You cut a rectangular strip out of the bladder wall, flip it upward, and roll it into a tube to act as a substitute ureter to reach all the way up.
Excellent. Now, iatrogenic prevention is a hot topic right now. Do prophylactic stents prevent ureteral injury during tricky pelvic surgeries?
The EAU guidelines are very definitive on this. No, stents do not prevent injury.
A scalpel doesn't care if there's plastic inside.
Exactly. The scalpel, or the harmonic scalpel, cuts through a polyurethane stent just as easily as it cuts through the ureter itself. However, they do make the injury much easier to recognize intraoperatively because you'll suddenly see the plastic stent, or the urine will leak more, obviously.
Now, there's a very specific study mentioned in the 2025 guidelines about ureteral access sheaths, something urologists use all the time for kidney stones.
Yes, and this is a very specific nugget that will absolutely be a board question. We know that pushing an access sheath up the ureter can cause mucosal tearing. A recent study showed that using silodosin, an alpha blocker, for 3 days prior to using a ureteral access sheath significantly reduced grade 2 and higher ureteral injuries.
That is fascinating. So the pre-op alpha blockers relax the smooth muscle in the distal ureter, making it wider and preventing the sheath from tearing it.
Exactly. The alpha-1 receptors are dense down there. Relaxing them allows the sheath to pass smoothly. Pre-op silodosin for access sheaths, write that down.
Moving right along to section 3, bladder trauma.
Bladder trauma is almost always associated with pelvic fractures if it is blunt trauma. There is a 60 to 90% association. If the pelvis is broken, suspect the bladder is broken.
And we classify these as intraperitoneal versus extraperitoneal. This is the classic distinction we all learned.
And the mechanism of injury usually tells you which one it is. Extraperitoneal ruptures usually happen when the sharp pelvic bone shards actually poke through the bladder wall, or the severe shearing force of the fracture tears the fascial ligaments holding the bladder base in place.
Okay, and intraperitoneal.
This is the classic seatbelt injury. The patient has a completely full bladder, they get into a head-on collision, sudden deceleration occurs, the seatbelt violently squeezes the full bladder, and it pops at its weakest, most unprotected point.
Which is the dome of the bladder, right at the top.
Exactly. And the dome is covered by peritoneum, so the urine bursts directly into the abdominal cavity.
Diagnosis, we obviously need a cystogram. But the guidelines are very particular about how we do this, not just any cystogram will do.
This is critical. You cannot just clamp the Foley catheter during a standard CT scan and hope the bladder slowly fills up with excreted contrast from the kidneys.
That's passive filling.
Yes, that is passive filling. And the guidelines state it is wholly inadequate. You will miss injuries. Because the bladder simply isn't distended enough to push the contrast out of the hole, especially if there are blood clots temporarily plugging the tear.
So what is the gold standard?
CT cystography with retrograde filling. You must actively push the contrast in through the catheter, and the guidelines specify the exact volume. You need to instill 300 to 350 milliliters of dilute contrast.
You really have to stretch it out.
You have to distend the bladder fully to prove that it is watertight.
Okay, so we do the retrograde fill, we take the scan, and we see a leak. How do we tell intra from extra on the image?
Extraperitoneal leaks stay down, low, deep in the pelvis. The contrast looks flame-shaped, or sometimes they say it looks like molar teeth. It is entirely confined by the fascial planes and the peritoneum.
And intraperitoneal.
Intraperitoneal contrast goes up. It physically outlines the loops of the small bowel. It looks like the contrast is just floating loose in the belly, because it is.
And the management algorithm for these? It's usually pretty binary.
Extremely binary. Intraperitoneal equals surgery. Always.
Why is that an absolute rule?
Because urine floating freely in the belly causes severe chemical peritonitis, and eventually the urea gets absorbed, and then it gets infected and causes massive sepsis. You have to open them up and sew it closed, usually with 2-layer watertight closure using absorbable suture.
Extraperitoneal.
Conservative management. Catheter drainage. The Foley keeps the bladder completely decompressed so no pressure builds up, and the hole simply heals on its own in about 10 days.
Are there any exceptions where we actually operate on an extraperitoneal rupture?
Yes. We call these complicated extraperitoneal injuries, and there are a few absolute indications to go in. Number one, if there is a shard of bone physically stuck inside the bladder lumen, if you leave it, it will become a permanent nidus for massive bladder stones or recurrent abscesses.
Makes sense. Number two,
if there is a concomitant rectal or vaginal injury right next to it, you absolutely have to separate those and fix them, or you will get a vesicovaginal or rectovesical fistula.
nightmare to fix later.
Huge nightmare. Number three, if the bladder neck itself is involved, this area heals very poorly with just a catheter and risks lifelong incontinence.
And the orthopedic scenario.
Right. Number four, and this is the most common one in practice. If the orthopedic surgeons are taking the patient to the OR to do an open fixation of the pelvis with metal plates and screws, they absolutely do not want infected urine leaking onto their pristine orthopedic hardware. So if they are opening the pelvis anyway, the urologist scrubs in and sews the extraperitoneal bladder tear closed.
That is perfectly clear. And follow-up for the conservative ones, the ones we just leave a catheter in.
You do a repeat cystogram at roughly 10 days. If it's completely healed, pull the catheter. If it is still leaking a bit, leave it in for another week and check again.
All right, section 4, urethral trauma. This is a big one, and this is where the management of men and women diverges significantly.
Huge difference. It is fundamentally different. Let's start with men. Specifically, posterior urethral injuries that are associated with pelvic fractures. We call this PFUI, pelvic fracture urethral injury.
And the mechanism here is a distraction injury. The bony pelvis breaks and shifts, and the urethra gets violently sheared off right at the apex of the prostate.
Exactly. The prostate is attached to the pubic bone by ligaments, so when the bone moves, it takes the prostate with it, ripping the urethra below it.
What are the clinical signs?
Blood at the meatus, that is the cardinal sign. Never ignore blood at the tip of the penis in a trauma patient. Also, the inability to void. And traditionally, the high-riding prostate on digital rectal exam.
But the 2025 guidelines have a specific warning about that rectal exam finding, don't they?
Yeah, they do.
Yeah.
The high-riding prostate is a classic old-school textbook finding, but in reality, in the trauma bay, it is highly unreliable.
Why is that?
Because a massive pelvic hematoma feels exactly like a boggy prostate to your finger. Or the hematoma is so huge it completely masks the prostate entirely. So don't rely on it. If there's blood at the meatus, you stop. You do not touch a catheter. You do a retrograde urethrogram, ARUG.
So to be crystal clear, do we ever put a catheter in blindly if we suspect an injury?
Never.
Yeah.
If you suspect a urethral injury, do not force a Foley catheter. You can easily turn a partial, incomplete tear into a complete transection just by forcing that balloon through it.
Okay, so we do the RUG, we see a disruption, the contrast leaks out, the urethra is torn. What do? This is the site of the great realignment versus delayed repair war in urology.
It really is. First rule, If the patient is unstable from their other injuries, you do nothing to the urethra. You just punch a suprapubic tube and SPT into their bladder to drain the urine, and you let the trauma team save their life.
But if they're perfectly stable,
If they are stable, you have two options. Option one, early endoscopic realignment. We call this railroading. You put a flexible cystoscope up the penis and another cystoscope down through the suprapubic tract. You find the two torn ends of the urethra in the hematoma, and you pull a single catheter across the gap to bridge it.
does this fix the stricture that's going to form?
No, it doesn't prevent it entirely. It reduces the rate of stricture, but dense strictures still happen in about 45 to 50% of these cases. However, the stricture that does form is usually much shorter and easier to fix later. The main advantage is that it aligns the two ends perfectly. It does not burn any bridges for future surgery.
And option 2, the gold standard.
Option 2 is just put in the suprapubic tube and wait. You let the masopelvic hematoma resolve completely, you let the acute inflammation settle down, you wait at least 3 months, and then you go in electively and do a formal delayed urethroplasty, sewing the healthy ends together. This has excellent long-term outcomes for patency.
What is the one thing we absolutely must not do in men with a pelvic fracture urethral injury?
Do not perform an immediate open urethroplasty in the acute setting, meaning less than 48 hours after the trauma.
Why not? Just sew it up while you're there.
Because it is an absolute bloody mess. The pelvis is a bowl of hematoma. You literally cannot identify the structures. The anatomy is destroyed. If you try to dissect in there to sew a disrupted urethra and a fresh pelvic fracture, the risk of massive bleeding, permanent incontinence, and permanent impotence skyrockets. Just don't do it.
Okay, that is super clear. Now let's pivot to female urethral injuries. They are relatively rare.
Very rare, but incredibly serious when they happen. Usually associated with severe, crushing pelvic fractures.
And the management is the exact opposite of what you just described for men.
Correct. In women, we do early repair. We want to fix it primarily within 7 days of the injury.
Why? Why don't we wait 3 months and let things settle down like we do in men?
It all comes down to anatomy. The female urethra is very short, and crucially, the delicate sphincter mechanism is deeply integrated in the anterior vaginal wall. If you wait 3 months, the scarring and fibrosis that forms will completely destroy that sphincter. It leads to devastating, unfixable incontinence and often severe vaginal stenosis or fistulas. Yeah, you simply cannot wait. You have to fix it primarily and early to preserve the anatomy and their continence.
That is such a critical distinction for the exam. Male equals wait, or do a gentle realignment. Female equals fix immediately within a week.
Precisely. Do not mix those up.
Finally, we are at section 5, genital trauma.
Let's start with penile fracture.
The pop and the eggplant. Everyone shudders when they hear about this one.
Yeah, the pathophysiology here is a traumatic tear in the tunica albuginea. Normally, when flaccid, the tunica is about 2 millimeters thick and very tough. But when fully erect, it thins out to just 0.25 millimeters.
It's stretched tight.
Right, and it literally snaps under sudden bending pressure, usually during vigorous intercourse when it slips and hits the perineum.
What are the classic signs the patient reports?
They will report hearing a loud popping sound, followed by immediate detumescence. They lose the erection instantly, and then rapid, massive swelling and bruising, which creates that classic eggplant deformity.
What if the history is murky and you aren't 100% sure it's a fracture?
If you are unsure, MRI is vastly superior to ultrasound here. An MRI will show you the exact location and size of the tear in the tunica, so you know exactly where to make your incision.
And the management.
Surgery. Immediate surgical repair.
Can't we just wrap it and give them ice?
Absolutely not. Do not treat this conservatively. If you treat a penile fracture conservatively, they have a huge risk of forming abscesses, developing terrible, painful curvature-like severe Peyronie's disease, and permanent erectile dysfunction. You take them to the OR, you deglove the penile skin, find the hole in the tunica, evacuate the hematoma, and sew the tears shut with absorbable sutures.
Got it. Now, testicular trauma. A kick to the groin, a sports injury, maybe a straddle injury.
For this, we use scrotal ultrasound. We're looking for a heterogeneous echo pattern inside the testicle, or a visible break in the tunica albuginea, which indicates a full testicular rupture.
What if the ultrasound is equivocal? The radiologist says, I can't quite tell if the tunica is broken or not. It's just really swollen.
If it is equivocal, you explore it surgically. The rule in trauma is time is tissue. If you wait, the seminiferous tubules will necrose from the pressure of the hematoma.
But there's another really interesting systemic reason you have to explore it early, right?
Yes, and this is highly testable. If the blood-testis barrier is breached by a rupture, the body's immune system is suddenly exposed to sperm for the first time. The body will actually form anti-sperm antibodies.
Because sperm are haploid, so the immune system sees them as foreign.
Exactly. And those antibodies will circulate and attack the healthy sperm in the other, completely uninjured testicle. It can cause permanent systemic infertility. So you must go in, evacuate the hematoma, trim away the necrotic tubules, and sew the tunicle closed. Salvaging the testicle is always, always better than doing an orchiectomy.
Amazing. Last and arguably most gruesome topic, amputation.
Right. The Bobbitt scenario. If the penis is amputated either self-inflicted or by assault, you have a strict time limit. Reimplantation needs to happen within 24 hours.
How do we instruct the paramedics or the ER to transport the amputated part? This feels like a very practical first aid board question.
It is. You bag the amputated penis in a watertight plastic bag. Then you put that bag into a slurry of ice water.
Ice water, but not directly on the ice.
Absolutely. Do not put the ice directly onto the tissue. If you put bare ice on the skin, you will cause severe frostbite necrosis, and you will completely ruin the graft. It will die. It needs to be kept cold to reduce metabolic demand, but completely dry.
And the surgical technique?
Microsurgical repair is heavily preferred over macroscopic repair. You need an operating microscope to perfectly reconnect the dorsal vein, the dorsal arteries, and the dorsal nerves to give them the best possible chance of recovering any sensation.
Wow. We have covered the entire urinary tract in record time. Let's try to bring this all together. What is the grand synthesis of this deep dive?
If I had to summarize the entire trauma philosophy of the 2025 EAU guidelines, it is this hierarchical four-step approach. Step 1, life before limb, damage control. If the patient is in the lethal triad hypothermia, acidosis, coagulopathy, stop operating.
Yeah.
Do temporary measures and get them to the ICU.
Step 2.
Step 2, solid organs like the kidneys. Try to save them at all costs. Conservative management is the default now, even for high-grade shattered kidneys. Use angioembolization aggressively if they bleed.
Step 3.
Step 3, hollow viscera like the bladder or the ureter. You have to fix them. Intraperitoneal bladder leaks need to be sewn shut to prevent sepsis.
And step 4?
Step 4, urethras. It entirely depends on gender. Men, you wait or do a gentle realignment. Women, you fix early and definitively.
That is a fantastic, concise summary.
And I actually have one final provocative thought for everyone listening.
Let's hear it.
We talk a lot in urology about technical surgical skill, how fast you can throw a stitch, how well you dissect. But in trauma, the absolute hardest skill to master is restraint. Yes. When you look at a CT scan of a shattered kidney, or you see a completely torn urethra in a trauma bay, your absolute primal instinct as a trained surgeon is, I can fix this. Give me a knife.
Right. We are trained to operate.
Exactly. But the 2025 guidelines are really teaching us that sometimes the absolute best surgery is the one you do not do, or the one you intentionally delay. Fighting your urge to dissect into a bloody pelvis to reconstruct a urethra can literally save a man's lifelong continence. Walking away from a grade 4 kidney laceration and just ordering strict bed rest can save the entire organ. It takes an immense amount of confidence and knowledge to stand there and do nothing.
Wow. Keep your guidelines close and your diagnostic threshold low. It's brilliant. That's it for this deep dive into urological trauma. Good luck to all of you on your boards.
Stay sharp out there.